43-year-old female, more than 1 month mild headache that improves with the painkiller. Severe headache on the day of her emergency room admission. Neuro examination, bilateral papilledema. This is her preoperative MRI showing a lesion located right at the region of the foramen of Monroe. This image is compatible with the colloid cyst of the third ventricle. This is additional axial cut of her MRI. So besides the choroidal cyst, she presents hydrocephalus. So for this region, it's the best approach is the interhemispheric transcallosal approach. But the question is, left side or right side? Which side should we go? To answer this question, we have to look at the place where the thalamus right vein will turn into the internal cerebral vein. If this we call as venous angle occurs more posteriorly, as we are looking at the right side. You see on the left, this is the thalamus right vein draining to the internal cerebral vein. So this vein is pretty attached to the colloid cyst, whereas on the right side, apparently this junction is more posterior, so leaving more room for me to attack the colloid cyst. So in this case, I would go definitely from the right side. So she underwent right frontal craniotomy, interhemispheric transcallosal transforaminal approach to the third ventricle colloid cyst. So for this kind of approach, it's very important to create space for retraction, because not only you have to go through the interhemispheric fissure, the patient has hydrocephalus. We didn't do anything, any external drainage, nothing. So we have to dissect and free the veins in order not to damage them when we retract the brain. Let's go to the video. So one of the maneuvers to preserve those bridging veins is to dissect the arachnoid around these veins, so this vein can be more free, so you can retract the brain without stretching too much those veins, bridging veins, and causing damage. So spend few minutes doing this kind of dissection, then we go to the interhemispheric approach. This is the superior sagittal sinus. This is the falx, and dissecting the interhemispheric fissure, separating the two cingulate gyri. So careful dissection, fine movement, callosal marginal artery. We have to go down. This is probably a pericallosal artery. This is the left, this is the right pericallosal artery, and this white structure is the corpus callosum. So pericallosal artery, corpus callosum. Bridging veins start to bleed, although all the maneuver I performed to preserve the veins, when I was placing the spatula, the vein starts to bleed. So I had to control this bleeding, and then back to the surgery. Genu of the corpus callosum. So where is the place to perform the transcallosal approach? Foramen of Monroe is typically 2.5 to 3 centimeters behind the genu of the corpus callosum. So that's why I used a ruler. I didn't have navigation at that time. This surgery was performed 5 years ago. So I've chosen the place to perform the collosotomy. And then because of the hydrocephalus, the septum pellucidum is in my way because the pressure on the left ventricle is higher than this on the right side. So you have to I made a puncture, made a hole to communicate both frontal horns. And then I am at the level, you see this is a fornix, this is a choroidal plexus of the lateral ventricle. This is the foramen Monroe, completely filled with the colloid cyst. This colloid cyst is small, you see it's here. It's small. So basically I don't have to split the choroidal fissure and perform the transchoroidal approach. All I have to do is to work around this small colloid cyst and see what places the colloid cyst is attached to, and then I cut and free the colloid cyst. We have to be careful not to manipulate too much the column of the fornix on the right side. So here is the choroidal plexus. So in this carefully dissecting, you see this is a choroidal plexus of the third ventricle. And try to be very gentle to mobilize the colloid cyst. So you do a circumferential dissection of the colloid cyst. You see this is a bridging vein, pretty much stretched but not damaged. So I'm still working around and trying to cut the attachment of the colloid cyst. So we're working on the posterior part of the colloid cyst over here. Try not to damage any vein, any caudate vein, any interseptal veins over here. Here's still the colloid cyst. This is the column of the fornix. You'll see the plane of a dissection between the column and fornix. This is the floor of the third ventricle. This is the interseptal vein. Be careful not to damage it. Dissecting posteriorly to the interseptal vein, cutting the attachment of the colloid cyst. So this is a colloid cyst, and dissecting carefully not to damage the interseptal vein. We know that interseptal vein will eventually drain into the internal cerebral veins back here. I don't see, but I know where it is. Continue to dissect. The posterior part is freed now. I have to cut this part. Coagulation. This is a choroidal plexus of the third ventricle, of the roof of the third ventricle. So it's been coagulated. So, and finally, the colloid cyst is freed. So I'm removing the colloid cyst. You see, this is the floor of the third ventricle after the removal of the colloid cyst. So you didn't have to sacrifice any septal vein, and then this is the final aspect of the surgery. You see most of the bridging veins have been preserved. She remained neurologically intact after the surgery. This is her postoperative MRI showing the total complete removal of the colloid cyst, and you see the gap of the collosotomy here, and also there's no more hydrocephalus.